Dear Chairman, ladies and gentlemen, let me introduce the EASY trial, the Early Achievable Severity Index in acute pancreatitis. The assessment of the severity is crucial because of the significant morbidity and mortality of the disorder. The revised classification in Atlanta recognizes three different degrees of the severity, the mild, moderate, and the severe. The majority of the cases are recognized as mild and moderately severe with associated low mortality rate, but patients who are at high risk for severe disease course require close monitoring and immediate aggressive treatment because of the high mortality. With respect to the clinical outcome of the acute pancreatitis, when we look at the mortality of the patients, so the mild patient, the mortality is almost around 1%. But in the severe cases, when we can divide the patients in sterile necrosis and the infected necrosis, we can see that the mortality is 5%, so increase compared to 1%. But the mortality in the infected necrosis is very high, so between 25 and 70%. The mortality is different. So we have the early and we have the late mortality. The early is because of the pro-inflammatory processes, and the late is because of the anti-inflammatory processes. So that's why, because of the associated morbidity and mortality, the severity and the assessment of the severity is crucial in the management of the disease. So that's why at the early stages of the AP, the acute pancreatitis, the determination of the severity is challenging. Multiple individual risk factors have been shown. The age, the comorbidities, the history of alcohol consumption, and also the obesity. We have a predictive scoring system, number of scoring systems that they have been developed for prognostication of the disorder. However, these current methods of risk stratification have important limitations. So in details, when we look at the different prognostication methods, the Ranson and the Glasgow, they collect parameters that are not routinely collected at admission. They require 84 hours to be completed, so 2 days. So this is when we're missing the early therapeutic window. So after 48 hours, usually from the clinical deterioration, we can see from the patient that it's going to be a severe acute pancreatitis. So it means the therapeutic window is already closed. The APACH-2 score was developed as an intensive care tool and requires a large number of parameters as well, and sometimes is not relevant to the prognosis of AP. The bedside index of severity in acute pancreatitis, this is a simple system. It has been recently introduced, and this is for early prediction of persistent organ failure and mortality. However, cannot easily distinguish between the transient and persistent organ failure, what is important with respect to the severe and moderately severe pancreatitis, and it's not widely utilized in general practice yet. The harmless acute pancreatitis score is also a simple system that can predict a non-severe disease course with high specificity with a positive predictive value of 98%. However, cannot distinguish between the moderate and severe disease course, and that's why, and I don't know, it's big because of this, but it's also not widely utilized in general practice. So these limitations might have an impact on the disease management and may influence the patient's survival. So that's why our hypothesis is that if we early recognize the severe acute pancreatitis with a simple, easy, and accurate clinical scoring system, we can actually prevent the serious adverse events and improve patient management and also the clinical outcome of the patients. So our aim was to develop a simple, easy, and accurate clinical scoring system that can be performed at admission during the first 6-12 hours. And we can also perform it in small hospitals where there is a limited access of diagnostic tools, and this can stratify patients in the early onset of the disease and stratify patients according to severe disease course. The design of the studies, it's an observational multicenter prospective cohort study already started, so we have already some patients collected there. The participants, so the inclusion criteria is adult patients with acute pancreatitis. The CFR is going to be the databases based on the Hungarian National Pancreas Registry. And the statistical analysis will be performed. What we actually talk to the statisticians, it's going to be data mining methods. And we have the ethical approval, and we are waiting for the register approved for controlled trials. How is the structure look like? First is the database. So we have the database already working. We are going to enroll patients with acute pancreatitis, collect parameters, and evaluate those parameters. And after those parameters will be utilized as selected parameters, we try to validate our EASY index. How it's going to work? So first start with the registry and the enrollment. As I saw that the data management, the database is our pancreas registry. It's an easy step. So regardless of the patient, when the patient with acute pancreatitis is getting into the database, there's going to be just one link to the EASY study if the patient is participating in EASY or not. So this is the only one small challenge on the database. Just to click on the EASY, and everything is going to go that way as the acute pancreatitis data collection. The patient will be hospitalized due to acute pancreatitis. The diagnosis is based on the criteria 2 out of 3. According to the recent guideline, and irrespective of the etiology, all patients with acute pancreatitis can be enrolled. And we will look at the mild, moderate, and severe patients. The target number of patients in the first part of the study is 900, and for the utilization, the validation, 300, so altogether 1,200 patients. So the second, the data collection and evaluation. So we have the patients in the database, so we collected the data prospectively from different centers. For this, we have uniform questionnaires. The questionnaires actually lead us how to collect and what kind of data to collect. And as I said, from the admission, from the first hours. So this is our main aim and hypothesis, that during the first 6-12 hours, we need to collect those data. The data are simple and simple to attain from the medical history, from physical examination, the laboratory test, and the diagnostic imaging. The data evaluation will be individually, each parameter will be statistically analyzed, and we'll try to assess its potential correlation with disease severity. So these are the parameters that will be assessed at admission or during the first 6 to 12 hours. We have these flyers available, so everybody can take it. We have it in Hungarian, also we have it in English. So these parameters will be assessed at admission of the patient. So right after that we collected the data, so we have to utilize it, all those parameters, to look at them and to do the statistical analysis. So those parameters that show the strongest correlation with severe disease course will be actually the potential prognostic markers. So these potential prognostic markers will be applied for the next prospectively, those 300 patients, as I said. So after those 900 patient data have been evaluated, so these factors, the selected parameters that can be potential markers, will be applied and will be prospectively used for patient stratification. And when we already did the prospectively collection of the new patient, we can compare the patient clinical course with the obtained results of early risk stratification. So we have the method, actually, what we can look at from the statistical analysis, that the patient is somehow going to be severe or mild, will have a mild clinical course, and we can compare it to the real clinical state of the patient. So as I said, the target number of the patient for the utilization is going to be 300. So in case of the correlation, when the correlation between the real patient clinical course with the obtained results of the prospective early risk stratification will be same, this is going to validate our parameters. So if we have the validated and utilized parameters, we'll have the EASY index. We are looking for 5 to 10 parameters, not more. As I showed you the table, we are looking for around 25 different parameters, as I said, from medical history, from the physical examination, laboratory test, as well as the imaging. we have chosen after a literature search that what kind of parameters should we look at. And the parameters have been already, that we have chosen, have been already used in different prognostication methods, like in upper score, Ranson, and the BICEP and the HAPS, PNC certification method. And also we are looking at those parameters that have been shown and been demonstrated that increase the risk of acute pancreatitis. Let me show you. So everything is on the database and everything is on the website. The letter of intent to join, the consent form. As I said, the uniform questionnaire is also available to download. And as we do in each clinical study, we also require for further genetic studies 2 EDTA tubes with blood stored at -20 and shipped to Szeged. So in summary, we think that by assessing the ability of selected marker for prognostication of the acute pancreatitis, our goal is to establish a new simple scoring system, and we hope that this early achievable severity index will actually in 2 years or 3 years from now, we can actually show this method as a working method. Thank you for your attention.
Okay, any questions? In the meantime, István, how are you going to organize that? Are you going into academic center mostly? Because it has to be very exactly filled out. You need to do it, you know, really with some effort. And when you want to cover all the Hungary, will you motivate the people from smaller centers?
We are not looking just in academical centers. This is what I tried in the introduction to tell, that our hypothesis is that we have to try to find a scoring system that can be available in each hospital. So that's why we are looking for those kind of prognostical markers, parameters that can be attained in each hospital. So it means that in a small hospital without big background with laboratory, so we are looking for those kind of parameters that can be easily obtained. And I think with respect to the questionnaires and what you looked for the clinical research form, so the questionnaires, I think those questionnaires can be filled out also by the administrative assistant.
Yes, and that's your plan, to go like everywhere, into any remote area?
So anybody who wants can join. So and it looks like that from Hungary we already have 8-10 patients.
And your experience that works?
It does.
Yeah. Okay.
And hopefully it will.
Yes, that's great. That's great. Any more questions, please? Okay, Peter?
I have just 2 comments for this study. One of them about the history, why we started it. Actually, and this is the reason why it's very good to have translational centers, because we do plenty of basic sciences. And what we found out that not almost all pancreatitis-inducing factors, strong mitochondrial toxins, and actually the intracellular ATP level depleted within the first couple of hours. So for us, like the pancreatitis, the same disease like myocardial infarction or stroke, you have a very, very short period to intervene. If you don't intervene in the first 24, 48 hours, you can't win the game. But when we try to thinking what kind of clinical study to organize, how to deliver ATP or so on, we just realized that first we don't even have a good scoring system at the beginning, just after 48 hours. You can imagine what would happen if you would have only a scoring system in stroke after 48 hours. Nobody could survive. So first, we need to come back to the beginning to see how it goes. And also, because everyone is afraid about how to collect data, because maybe there is not too much money in the eastern part of Europe. But for example, about what you mentioned, whether in smaller centers it's achievable. Yes, for example, in the upper score require arterial pH measurement. Almost nobody using even big centers. But here in this study, there is only like counting the breath rate. It's above, maybe 20, below, or so on. Or maybe there is pleural fluid looking at with ultrasonography, which is not additional prices. So this is why István could say that it works in a smaller hospitals too. because they require only a small amount of money, and but needs attention, that's for sure.
Definitely basic parameters are going to be obtained.